The biggest one we're doing right now is Stampede 3, of course, where we've actually taken people, anyone with chronic symptoms that they can relate back to deployment. We've done a very comprehensive workup on them. So Stampede 1 was a lot more limited. We did more basic things. This one, if they come to my office, they get the whole shebang. So we do breathing tests, exercise tests. We look at their vocal cords. We do imaging. We check for asthma and a variety of different testing. We do bronchoscopy and look at their airways. We've put in some fluid, pull it back out, and send that off for testing as well. So they get a very comprehensive workup. We're now doing that here, up at Walter Reed, over at Wolford Hall, and we have permission to do it up at Fort Campbell. Many of our soldiers have come from Fort Campbell. We haven't started up there yet. And we've got over 200 patients enrolled in this study so far. And the initial trends are not too surprising. We're finding a lot of folks, over about half the folks that we diagnose, that have asthma, very typical for what the population is. Some with just airway hyperreactivity, some with problems like vocal cord dysfunction, and a variety of other smaller problems. But we're not finding very few of our patients have chronic changes on their CT scans or interstitial lung disease or other small airways disease that has been suggested by other people in other studies. So we've looked at those. We have looked at, retrospectively gone back and we've looked at patients with asthma, with sarcoid and with COPD, and look to see if there's any differences between the deployers and the non-deployers, and really haven't found any difference in severity or degree of illness in any of those populations. So we're not, while it may aggravate things like asthma, we haven't found anything specific that really says, yeah, there's a bigger group of people coming back with chronic lung disease. Although the literature would suggest there's a lot more symptoms. So far we're the only ones who have done a prospective study to look specifically at what those symptoms entail, and do they actually mean lung disease or not, and what the types of lung disease are. For instance, looking at all the patients that got biopsied within the DoD healthcare system, and looking at their diagnoses and to see if there's any differences between those that deployed and those that didn't deploy. And we just sent that paper off for publication and didn't really find a big difference, a few small categories. But things like small airways disease, we didn't find a big increase in the deployed population at all. So we're not exactly sure. We think there's definitely individuals who go over who get lung disease because of the environment, partially because there's a lot more dust. There are some, there's a lot more smoke over there. There's in some places, right now, like in Afghanistan, in some of the cities, the pollution is a lot worse than what we ever see here in the United States. And so we probably have individuals that are prone to developing disease in the right environment develop it, but we're not finding widespread problems in terms of a lot of people with unusual lung diseases. We hit and miss. We have individuals, as you'd expect. We've sent over 2.5 million people to that area, and so some people are going to come back with some lung diseases. Part of it we think may be due to increased smoking, because clearly when you're not doing anything and there's cigarettes and everybody else is doing it, there's a higher increase. We know there's an increased rate of smoking in these individuals over there as well. No. One of the differences is they were, at least in one of the civilian studies, that they were a lot more aggressive in they're taking patients and doing surgical lung biopsies. We've only done that on a selected few individuals that we have found specific changes on their CT scans to do that. The lungs are exposed to the environment all the time. And if you biopsy anybody, you're going to find some stuff. You're going to find some changes. We breathe in, yes, some people are smokers, some people live in certain environments where there's a lot of dust and whatnot, and you'll find something in there. The question remains is what they find actually equate to what was causing their symptoms, and we're not sure about that. So we're trying to do a less invasive a lot less invasive approach to it, and only biopsy those people that have specific changes that we can identify and try to figure out which, what that is. Part of that is, I think, their approach. Part of it is if you have pathology, the pathology doesn't necessarily equate to the disease. Sometimes it does. I mean, clearly we know patients that have bad idiopathic pulmonary fibrosis. If you biopsy them, you can find all the specific changes with them. But in this case, at least, nearly 85% of the patients that they biopsied had normal PFTs and normal CT scans. So what does that mean when you have a normal CT scan and you find some changes? I don't know if anybody knows exactly what that means. And so we're trying to look at more from an exercise standpoint. Can they exercise? How far can they exercise? What do the breathing tests look like? And I think one of the things that nobody has the answer to, and that's one of the things we're doing, we have a registry set up, is are there long-term outcomes that we're not seeing immediately, after they redeploy or after multiple deployments, and trying to follow these patients a lot longer and seeing what their outcomes are. So even if they have some changes, but not significant changes, following them over a period of years to see if that changes, it stays the same, gets better. Just saw a guy last week who clearly, back in 2009, I didn't see him back then, had changes on a CT scan. He was being sent for an evaluation, had the PCS, so he sort of dropped the whole thing. And finally came around to us in the past year, and looking back, yeah, there were changes, but they went away. But he still got some persistent changes on his PFTs. So we won't be able to tell exactly what he got exposed to or what that was, but clearly there was. And there have been a few people, I would say, less than 5% who have had some unusual lung diseases that we wouldn't typically see in the population if we worked them up. And so we can't say that nobody gets anything related over there. We just don't think the problem that was described, at least in these articles, was as extensive as they thought it was. So we're trying to, make sure you work up the common things first. Asthma, COPD, vocal cord dysfunction, and the common things that we found in a previous study, and do those first, and then if you don't find anything else, start looking for more unusual things. And so our approach has been a lot more conservative, I would say, than what they were doing. We found some unusual things that if we hadn't been doing this, we would have probably not, we probably wouldn't have picked it up. We're finding, for instance, we have a group of 6 individuals we've seen on the study that because we're doing all the exercising, we've found that they have large airway collapse when they exercise. They make this big loud noise. We've been able to identify that it's either the trachea or the mainstem bronchi that are collapsing, and that's never been reported, at least in that population. It's been reported in patients with COPD and asthma, but not in this population who are otherwise healthy. So there's a few things that we have, because we're very extensive in looking at everything, a few things that we didn't think about too much maybe playing a role in the symptoms in these patients, other than just the fact that they're getting older. So, I mean, that happens to everybody.